Let me get that a little straightened up and we'll get started.
Sure.
Can you still see the slides?
Yes, I can.
Okay. So what I thought I'd do today is go through some basic information of partial breast irradiation, because there's been some new data, as you probably know, that just came out the other week at San Antonio Breast Conference. So set the stage for the discussion. I put down some thoughts that I think where we need to go with some of the next sort of steps to usher in partial breast a little bit more clearly into the typical treatment schemes. And then obviously this is about AccuBoost, so I thought I'd talk about some of the work that's being done with AccuBoost, dominantly the work that's being done up at Tufts Brown with Heppel and Dr. Wazer, and then we can answer any questions and talk about any directions you guys would like to go. Sure,
that sounds great.
So this is a slide that Dr. Ficini put together that I think has been very helpful. I updated it, but these are, we've got all these phase 1 and phase 2 trials that are out there, and there's all this information, but when it really comes down to it, we really, at this point, can just focus on our phase 3 trial. Okay, so this red box around here shows you the phase 3 trials that have been published, and when you look at that and you total them up, we've got over 4,000 patients now with excellent control rates, which you can see down here at 5 years, and solid follow-up, some of them longer than others. We also have the RAPID trial from Canada and the B39 trial from the United States that have just been reported, and I'll go over that in a little bit more detail. But again, we're showing excellent 5-year control rates and over 6,000 patients. And then we have 3 trials that are still accruing, which are going to add another 6,100 patients. And when you look at it, I mean, it's over 16,000 patients trying to look at whether or not partial breast is acceptable or not. And if you go back over the data, I mean, my goodness, the B06 and Milan trials only totaled 2,500 patients. So we're really sort of overstudying this concept to some degree. So the JEC-Estro has been published, and we're going to go over that in a slide in a second. The import low, although it was not a truly accelerated trial such as a 1-week treatment, it was a partial breast target, so it's very important to our discussion. And then the RAPID and NSABP was just presented on December 6th, so that's all fresh data. So if you look at the JEC-Estro trial, as you know, that was published in 2016. This is a randomized phase 3 trial. It's only brachytherapy. It's selected women, so greater than 40, early stage disease, both non-invasive and invasive. They required a 2-centimeter margin pathologically. If it was invasive lobular, they wanted a 5-millimeter margin. There was LVI was not accepted. And in their randomization of over 1,000 patients with 5-year follow-up, they got excellent results in regards to the cumulative incidence of in-breast recurrence and equivalent in regards to their outcome. They did look at the toxicities. There was a suggestion that maybe partial breast had less toxicity than whole breast, but bottom line is that they had excellent results and set the stage in a phase 3 trial that partial breast done with brachytherapy is appropriate. When you look at the import low trial, which is another strong trial, you have 30 centers within the UK that contributed, and over 50, greater than 50 years old, early stage disease, less than 3 centimeters, 2-millimeter margins, and 0 to 3 positive nodes were acceptable. They randomized between 3 arms. Their standard accelerated whole breast of 40 gray and 15 fractions versus 36 gray to the whole breast while delivering 40 gray to the partial breast. It was sort of a slight de-escalation of the whole breast dose. And then they did a 40 gray just to a partial breast target. These were not highly formal fields. These were just reduced partial breast fields, making it quite easy to deliver and getting off heart, lung, and so forth to make it toxicity, to avoid anything regarding toxicity. Now, they had over 2,000 patients with a median follow-up of 72 months at the time of presentation, and you can see their 5-year cumulative incidence here was excellent at 1%, and so really proved the concept once again that partial breast radiotherapy in these selected patients is appropriate and is as good as whole breast radiotherapy. They did look at photographs, patient evaluation, and as well as health professional assessments of adverse events, and they felt that the the breast appearance as well as the firmness of the breast was statistically significantly better with partial breast versus whole breast. Certainly there's some subjectivity to that, but does provide some interesting things to pursue. Now, the RAPID trial has been going on for some time. As you know, this is a 3D conformal partial breast approach. They had a slightly highly selected group of women. In other words, they included greater than 40 years old, invasive and in situ disease, less than 3 centimeters, negative margins, and negative nodes. But when you really looked at who they actually included in the trial, was more heavily selected. In other words, they were greater than 50-year-old women predominantly, smaller than 1.5 centimeters predominantly, ER positive predominantly, and grade 1, grade 2 predominantly. So a highly favorable group of women. They were randomized to the 38.5 and 10 fractions delivered twice a day for 5 days in a partial breast setup versus a whole breast. And those patients could be treated with hypofractionation, or they could be treated with standard whole breast radiotherapy in 25 fractions. And about 21% of those patients received the boost. Interestingly, now with 8.2 year median follow-up that was presented, the median age of those patients was 61 years, which is important to remember when we look at the next trial, the B39, over 2,000 women, and they had excellent in-breast control rate. So their in-breast tumor recurrence rate at 8 years for partial breast was 3% and 2.8 for whole breast. Their disease-free survival, event-free survival, mortality, there was no difference. And so they had excellent results in regards to control. The issues that they found, however, is that the grade 3 toxicities, although they were rare in both arms, their cosmetic outcome at 7 years with partial breast was not as good as with whole breast. This is with digital photo review as well as patient and trained nurse questionnaires. And you can see there at the bottom of the slide that there's about a 36% fair to poor cosmetic outcome versus a 19% with this technique across the board. Now, Dr. Whalen did comment that when you talked about fair to poor cosmesis in these patients, most of them were fair and they weren't poor. So they were close to that line between good and fair, but nevertheless, they did not feel that the cosmetic outcome was quite as good. His comment is that possibly the BID treatment is just too robust for the normal tissues to handle, and a different fractionation scheme would be preferred. He did make comment that maybe brachytherapy based on the Jack-Estro trials might be a preferred technique, at least at this point. When you move on...
Douglas, can you hear us? This is Dr. Sareen and Dr. Tabassum. We were listening to you for last 5 to 10 minutes, but our camera and was not on, so now we joined the other end.
Okay, great.
Thank you. Bye.
So the B39 trial was also presented last week, and it's slightly different than the RAPID trial. And as you remember, we included a larger range of patients, younger women down to 18 years old. liked rapid, both invasive and non-invasive disease, less than 3 centimeters. There was a group of patients that were included that had 1 to 3 positive nodes. ER positive and ER negative were included in this trial. We weren't concerned with extensive intraductal component, but we did want to make sure that they had negative margins by the definition of no tumor on ink. Now, the median age in this group of patients is younger than the RAPID trial. It was 54 years, so we had a larger range of age in this study. And as you remember, after breast-conserving surgery, they were randomized to whole breast radiotherapy versus partial breast. And the partial breast treatment techniques could be 3D conformal, the single-lumen mammocyte. We later added in the multi-lumen devices, but they didn't contribute very much, or multi-catheter. These techniques were up to the individual physician and patient, so there was no stratification of these techniques. And we did our best to dosimetrically make them equivalent where we thought we could at the time. About 70% of the patients on this trial were treated with 3D conformal, about 25% with intracavitary, and about 5% with a multicath technique. The patients were stratified based on disease stage, so non-invasive versus stage 1 versus 2, and they were also stratified for menopausal status, as well as hormonal receptor status and the intention to receive chemotherapy. In hopes that we could maybe pull out a group of patients that were not appropriate for partial breast, or actually to include them as officially in a partial breast treatment, appropriate to treat with partial breast. Now, the data was presented last week with a median follow-up of 10.2 years, and the difference between whole breast and partial breast was only 0.7%, with an in-breast tumor recurrence of 3.9% for whole breast and 4.6% for partial breast. Now, the statistical gymnastics that are included in this trial are that it was designed as an equivalency trial. And when you look at the 90% confidence interval, technically, from a statistical standpoint, it did not meet equivalence. But when you pulled those recurrence rate out to 10 years, it was only 0.7%. I think you would agree that it's not really clinically significant. And when you look at statistics, it really didn't prove that partial breast was inferior. So you get into this statistical quagmire of how they designed the trial, but in the end, it was only a 0.7% difference. When you look at relapse-free interval, distant disease-free interval, disease-free survival, and overall survival, there was no difference. When you looked into the subgroups, the confidence intervals were so large that we really couldn't pull out a group of patients that was clearly inappropriate for partial breast. We can start to talk maybe about positive nodes and things like that, but I think we're going to need some more time looking at the data to really make some robust statements about that. The only statistically significant finding in that subgroup was that partial breast had a better control rate than whole breast for lesions less than 1 centimeter. Other than that, there was no statistical significance between these subgroups.
Douglas,
yes.
Rajiv, we are familiar with these trials, so I think if we can have more focus on this technology, the AccuBoost, if you have any, you can share your views. That will be more helpful, I think.
Yeah. No, I'm moving on to that. So my thoughts on technique and where we go is I think we've proven partial breast.
Yes.
The question is it where we proved it to be, the twice a day for 5 days, is that really an improvement for the patient? Is there something we can do better? Is it invasive versus non-invasive? What do we do with these different techniques, and how do we focus in to really make a benefit for the patient? Because now we're comparing it to whole breast that's getting done in 3 to 4 weeks.
Yeah.
So what I've been thinking about is where's the benefit to the patient? So can we shorten this treatment? If we can we also shorten the boost delivery? And how is it best delivered? So in brachytherapy, as you know, there's some preliminary work looking at shortening the course. 7 gray times 4 has been looked at. There's a small trial that's been done with 200 patients. They just finished at 7.5 times 3. Maybe there's some benefit there. Maybe there's some direction there with the brachytherapy that would make it a little bit more palatable and quality of life focused for the patient. But let's look at the non-invasive, because obviously if we can avoid an invasive procedure, there's some benefit to the patient. I don't think that 3.85 BID for 5 days makes a lot of sense based on 1, patient convenience, and 2, the cosmetic outcome that the RAPID trial is showing. We have to look within the NSAB PB39 data to see if that's a good idea. So maybe once a day over 10 days is a good approach to start. But the Florence trial, they've got 240 patients out 5 years. That was 6 gray times 5. Maybe that's a better way to go. And maybe we could utilize the fast forward fractionation and go at 5.4 gray times 5. So I think there's some fractionation within the non-invasive treatment that would truly improve things. Okay. You know about these techniques as much as I do. So let's just go on and focus on the AccuBoost and where I think the benefits are. So I'm going to borrow some slides from Dr. Heppel and try to focus these slides towards you guys, and then we can go on to any questions that you have after that and get into a discussion. Okay. So we're going to review the rationale for this non-invasive breast brachytherapy, AccuBoost, review the technique. There's some preliminary trials that they've done at Tufts and Brown that I think really help us get an understanding of the benefits of this technology, and then throw out a couple ideas that I've been thinking about along with Dr. Wazer and Dr. Heppel that where this may go. So this is the unit. I'm sure you've seen this. It's a mammography unit that's been modified to handle these applicators. It's novel because it's non-invasive. We have daily targeting, so we don't have setup issues in regards to whether our patient is breathing or moving out of our field. So we don't need fancy immobilization because this compression. Is
the patient sitting or standing? Is the patient?
I've done it both. I've done it both ways. Okay. We tend to do it sitting for obvious reasons. It takes a little while to deliver this, and there are some slight little tricks you can do with the angle of the head of the unit that can actually make this quite easy for the patient and their comfort. But yes, we have a chair that we can actually lock into position so that we don't have to worry about the patient's comfort or movement. Okay. So because you've got an immobilization of the breast, we can reduce the PTV margins because we don't have to worry about that. It is image guided. And with the collimation of these applicators, you get a nice precise dose delivery. And certainly this uses HDR, Iridium 192 as the source. But I think one of the benefits that this technology brings that is a concern of a lot of us using non-invasive is the amount of tissue that gets treated, and this allows us to reduce that target down. You can pretty much see the unit here, the compression plates down here, and then there's a digital cassette down at the bottom for easy obtaining of the pictures. Now the patient is placed. You see the patient standing here, but certainly sitting is fine. As I mentioned, there's some tricks we've learned to angle the head of the unit and to position the patient. Once you learn those, it's actually quite easy to get these patients into position. I usually have a wire on the scar just as an orientation to help for a little bit quicker application. And then after the compression, you get a picture so that you know where the patient falls within this grid. And therefore, you can pick out the exact coordinates that you want to place your applicator. The new modifications of the unit that happened a couple years ago actually make placing of these applicators onto the compression plates very easy and very quick. And that way you've got accurate delivery of the dose. You can see on the right side of the picture that the iridium source travels out along and around the bottom of the cup to deliver an even dose around there. Pretty straightforward and easy for the dosimetrist and physicist to plan and prepare. Obviously, the dose is based on the separation, the source strength, as well as the specific applicator that you choose to use, and certainly the dose. You can see another application here. So what initially when we started this, we were just doing it as a boost. We were doing 5 fractions. We were treating compression in one direction one day and the orthogonal in on the next day. That worked fine for a 5-fraction boost, but when we tried to reduce the amount of boost in terms of fractions, we didn't feel comfortable delivering it through a single plane, and so we deliver half the dose through one orthogonal plane and the other half the dose through another on a single treatment, so that you're spreading the dose around. And I think you can see this treatment here, where on the left panel one direction and on the middle panel is the other. But if you do all 4 at one time, you reduce the skin dose each day and still achieve your conformal dose delivery. So by doing this compression, we're immobilizing the breast. With the separation reduction, it allows this applicator, and the way the dose distribution, we're able to reduce the skin dose because we don't have to deliver the dose quite as deep within the breast tissue. And we're displacing any non-target breast tissue out of the radiation field with that compression. So the potential advantages here: it's non-invasive, so it's going to be more acceptable to the patients. Risk of infection, any of these other problems with invasive procedures, goes away. The immobilization allows for smaller PTV margins and therefore decreases the risk of the toxicity to the breast. If you're dealing with oncoplastic surgery, we don't have to, the indwelling balloon catheters you're just not going to be able to do it. Often clips are left behind, and this technique just works nicely with that, because you know exactly where things are, and the surgeons can do what they want to do. And then there's potential for improved cosmetic outcome simply because it's a smaller and controlled field. And I added this in. I think there's it's less expertise dependent. Brachytherapy with multi-catheter goes very well when the person doing it has the ability, but this is less dependent on that, and can be set up quite easily and reproducibly on each of the patients. So Dr. Heppel and Dr. Wazer started a trial just to get some experience with this technique. In my opinion, and I think you would agree, if you're delivering the right dose to the right target, you're not really worried about whether you're controlling the cancer. You're worried about patient convenience, setup, reproducibility, and reliability of your treatment, and obviously the normal tissue dose. And so I think that we feel comfortable that the dose is being delivered to the target. The question is how is the patient tolerating it? How easy is it to set up? What kind of time is involved? So they did an initial trial doing the standard 3.4 gray times 10 as a partial breast treatment approach. They used a 1 centimeter margin, and they used the 2 orthogonal axes for each treatment to spread the skin dose around and reduce it to as low as possible. They required at least an 8 centimeter separation or less to make sure that their dosimetry was optimized. They either treated them daily, so once a day for 10 days, or BID, depending on how quickly the patient wanted to be done with their treatment and the convenience of coming in. Had a pretty expected low-risk group of patients here. They accrued 40 patients to the trial. It was done prospectively on an IRB-approved trial. In their experience and their questionnaires, all patients tolerated the treatments well. The treatment time is about, they have an average of 14 minutes per axis. Obviously, it can go very quickly if the patient sets up easily. It can take a little longer if you need to do a little bit of adjustment to get things going well. And when you treat both axes on the same time, again, it ranges from anywhere from 30 minutes to an hour. But again, as you get better in treatment setup and you know the little tricks, it goes quite quickly. What we've done here is when we're assessing the patient as to whether they're a good candidate and we can visualize things well, the patient tolerates it well, we'll work on those axes at that time so that when we're doing the actual treatment, we know exactly what we're doing with setup, what angles we want to use so it moves quickly. We know whether the patient, is sitting, standing, what's the most comfortable thing. So when actual treatment comes along, we're not trying to figure that out. Discomfort from the breast compression, it's actually incredibly well tolerated. You see here with their on a 10-point scale of pain, the patients had a range, but the median score was very low at 1. And certainly you may run into an occasional patient that has some post-surgical pain that is accentuated with this treatment approach, but I've been impressed with how well they've tolerated it. And, treatment-related fatigue, yeah, we need to check on that, but you wouldn't expect much. This isn't a large field, and the patients tolerate it extremely well. In regards to the skin reaction, I've been impressed. The new applicators, which I have a slide or two on, really allow us to reduce the skin dose to an acceptable level. In their trial, there was some grade 1 faint erythema in half the patients and some moderate erythema grade 2 in about a quarter of the patients. Nobody developed a grade 3 skin reaction. I've never seen a grade 3 skin reaction. And this includes women where you have a superficial target and your applicator extends outside the skin contour. And so you would expect perhaps a little larger skin reaction in that area because you have some tangential beam. I've been impressed with how low that really occurs. It's rare. Typically, if you have the applicator extending outside the skin because of a superficial field, it's only in one axis and not both. And so the skin dose is still preserved as low. So there has been some changes in the applicators, and without going into extreme detail, rather than just having a straightforward applicator round that you see at the top with a thick wall that delivered a very uniform dose, with a skin dose that at those initial fields we were getting not a brisk reaction but a little bit of erythema that was a little discomfort. They've modified this. They have modified the shape so that you shield part of the beam so that some of the tangential aspect of the way the scatter hits that skin is reduced, which reduces the skin dose. They've also been able to lower the profile, which allows the doses to be delivered quicker than it was before and shorten the treatment times. They've also developed a D-shaped applicator so that those deeper lesions where you need a flat surface instead of a round surface against the chest wall to get those deeper lesions. And they've also gone ahead and reduced the thickness of the wall on the back end of the D applicator, just so that you can get a little deeper dose on those deep applicators. And the bottom line for me going through all that is the company has continued to look at the treatment, get feedback from their users, and have quickly innovated to improve the technology, and by doing so have reduced the skin dose, reduced the treatment time, and allowed us to be able to cover the target in some of these difficult locations. Late outcome from this trial with a median follow-up of 2 years has shown, things you would expect. You really wouldn't expect recurrences to be very high, and they're not, so there's no surprises. And no real problems. If you look down lower, the grade 3 toxicity, which is what we would really be looking at here, it did not occur, and there's been no subcutaneous fibrosis, grade 2 or grade 3, and good to excellent cosmesis at a 2.5-year follow-up, or a 2-year follow-up, which I think is important when we start thinking about this technology. So in conclusion for this initial trial, patients tolerate it well. It's feasible and easy and reproducible. Skin reaction is mild to infrequent. Really virtually no skin reaction with these new second-generation applicators. And the early results show that the outcomes at 2 to 3 years are favorable and very encouraging, and certainly compare in a better way to standard 3D conformal technique that's been reported. So the current recommendations, if this is used for partial breast, is to use a dose of 36 gray and 10 fractions, and that allows, whether it's BID, which is inconvenient for some patients and sometimes with the clinic, but certainly daily over 2 weeks is easy to do. 1 centimeter margin, and then treating 2 axes per fraction to reduce that skin dose. The recommendation is to make sure you can compress to less than 8 centimeters, also for dosimetric reasons, and try to, when you choose your orthogonal axes, it doesn't have to be a perfect orthogonal 90-degree pair, but you want to make sure that the skin and the 2 axes do not overlap, so that you reduce that skin dose. And obviously use the new applicators because they're dosimetrically favorable to the originals. Now, I think that this is probably where it needs to go, and using the fast forward trial that the UK has piloted, that fractionation scheme that they're using for whole breast, as you know, use it for partial breast, which would get this down to 5 fractions, would be more convenient for the patients, and move things through. And I think that's where it needs to go. Dr. Heppel and Dr. Wazer have already piloted this. This is in a favorable group of patients, as you would expect, based on ABS guidelines, and they were looking at acute and intermediate toxicity, as well as long-term cosmetic outcome and in-breast tumor recurrence. A sample size of 40 patients. There's no reason to believe that disease control would be a problem. We're really looking at patient tolerance and toxicity. So they have a median, they've treated 40 patients. They've just presented this at Astro with a median of 14 months. Again, a favorable group of women, not surprising there. And again, treatment time, patients tolerated well. Their average treatment time was about 20 minutes per axis. So it's a little longer because the dose is higher per fraction than previously delivered. The discomfort for the patient was, again, well tolerated, so we're being consistent with our previous experience. And from the early results, the toxicity, even with this dose fractionation, was quite favorable, with only 1 patient that had some grade 3 skin reactions. Most of them were grade 0 or grade 1. Wouldn't expect any recurrence at this early date, but it's good to see that there weren't any, and no grade 2 or higher toxicity at this time point. Cosmesis is good to excellent in all patients, and again, favorable outcomes. So this treatment is well tolerated. Skin toxicity is mild. There was a few patients that had a little higher acute toxicity than in the previous, but again, the dose is higher. They'll need to follow up this dose to see what happens with that skin in those few patients that had a little bit more robust skin reaction. Their assessment is the skin toxicity is associated with the treatment volume and the separation, and that it may be avoided by limiting this 5-fraction approach to the smaller applicators, which makes sense, as well as in the patients where you can reduce that separation to less than 7 centimeters, because as you know, that improves the dosimetric properties and reduces the skin dose. And so by doing that, the early outcomes of the late toxicity and cosmesis appear to be very good. We have a data registry that anybody that's involved can contribute to, and I think that's helpful just to continue to build a communal data pool that allows us to get as much information out of this as possible. And this is maintained, and already they have about 100 patients that have been done with partial breast. Right now, most of them are boost, but growing quickly with partial breast patients. So one last thought. I won't spend much time on this because this really isn't about the technology, but I think this technology could lend this to this new approach. As you know, there is a lot of talk about preoperative treatment. The concept is quite straightforward. The preoperative short course using image guidance, either with stereotactic IMRT, but now with this AccuBoost technology, really it lends itself to that, because we can identify the gross tumor volume, the CTV. We could extend as per guidelines, but now this becomes a tumor-centric target rather than a seroma-centric target, because we all know the tumor is usually eccentric within the seroma, and therefore we can further reduce the target size and treat less tissue. So it's a tumor plus margin rather than a seroma cavity plus margin. So I think the concept makes sense. Now, there are some places that are looking into this. The Dutch have done some early work looking at pathologic results after preoperative, as well as Duke, both showing some interesting findings and actually suggesting that maybe if we do this right with our doses, we might be able to get into an ablative type of treatment that may actually remove the need for surgery. Obviously, that's far off, and a lot of work needs to be done with the treatment delivery. There's been a number of areas with different technology, both the gamma pod as well as stereotactic, that have looked at this. That are looking at this treatment as we speak. So there's a lot of trials out. I personally think this AccuBoost technology falls into this quite nicely as compared to the others for the reasons we talked about in regards to motion control, stabilization, target definition, and the visualization of the target for treatment. But that's sort of my presentation. I'm more than happy to talk regarding any questions you have. I can't hear you.
Okay, Doug, can you hear me?
Yes, I can.
Yeah, I
can hear you.
Okay. So I think the last, using radiotherapy alone, I think that is most exciting. I look at it like in prostate cancer, you can do it, the disease of the elderly, hormone receptor positive. You treat with either radiotherapy alone or surgery alone, with or without hormones. Maybe 10 years, maybe breast cancer to be treated like that.
I agree.
So what kind of studies which are going on, not just preoperative or in terms of radical, of course, initially you'll have to show preoperative. There's a PRADA study and other studies are going on. So you all are, there are several studies. Any study which you all are participating, preoperative RT or radical RT?
I'm sorry, are there any trials that I'm involved in?
Yes,
I
yes.
I am not involved in any of those at this moment. They have tended to be very facility specific right now because they're small trials looking at pathology and so forth. We're sort of starting to gear up to see where we can get involved in this investigation because I think that's sort of where we need to go. Both Duke and Maryland have sort of led a lot of this work in the United States. Are still trying to work out some of the fractionation to make sure that the toxicity is low. So I think that's a fertile area to explore.
And how much time we should wait if you look at the pathology after preoperative radiotherapy? 4 weeks should be sufficient, or it should be shorter because patients. So if preoperative, most of these studies.
Yeah, if you look at some of the stuff in Duke, I think it may be even a longer episode of time because, as you know, it may take a little while for things to respond to the treatment. So they're actually waiting a couple of months.
Okay, couple of months. Okay. So other question was in terms of the logistics and feasibility. How much each patient spends inside the treatment room? About an hour or longer? Or how much?
Right. I think it'll depend on the dose you're delivering.
Yeah.
But if you look at the data from Tufts Brown, there was a range. It could be as short as 30 minutes and it could be as long as an hour. And I think a lot of that has to do with how easy the setup is and how good your team sort of picks up the little nuances of getting the patient in position quickly.
Okay. I think that's now it has normally you have got another HDR machine, Iridium 192, or inside your HDR machine you have placed this unit.
I think it's breaking up a little bit, but I think that you were asking about the HDR machine. You just connect whatever HDR machine you have would connect up to these applicators. Is that what you're asking?
Yes. That means this AccuBoost equipment has to be in the HDR unit.
Yeah, the AccuBoost equipment right now is located in our HDR location.
Okay, that's what I wanted to clear.
Yeah,
So I have a question.
It's not real big. It's not real big and sort of fits in the corner of the room, and has not been a problem.
So for this one,
just one note, Dr. Sarin. The statistics from sites, just to give you a better sense for timing, typically they allot a half-hour block for boost and a 1 hour block for APBI. Typically they are finished before those time blocks are complete, just from a planning perspective. And I would also add, Dr. Arthur talked about the preoperative trial. The same group at Rhode Island Hospital, Dr. Waisner and Dr. Heppel, have actually commenced a preoperative study with AccuBoost. They have received FDA clearance, and we expect to begin accruing patients in January.
Okay, that's good.
And I will mention that Dr. Waisner is looking for potential international collaborators for preoperative studies. So if that's of interest to you, we can certainly connect you with that team.
Okay. Yeah.
Well, Dr. Arthur had mentioned he has a hard deadline at 5 minutes to 8 o'clock, and we're just about there. So, Dr. Arthur, I just wanted to thank you so much for your time. Sorry for the connection problems at the beginning. And Dr. Sarin and your team, we really appreciate your taking the time out of your schedule for this. Certainly, if you have any follow-up questions, we'd be glad to help facilitate getting any of those answered. But otherwise, we thank you for your time. And unless you have any other questions.
So I'm sure we have some questions. We will, send them to you. So if any of the preoperative trials, as you mentioned, if you can share those, the links for those trials, we can read up about them.
Okay. Yeah, I'd be glad to put something together, and feel free to email me with any questions about any of this. I'm more than happy to help out.
Sure. And you have this unit at, maybe once I'm visiting, any one of us visiting, we could see your unit, how you actually use it.
Yeah, certainly. We can work something out. Absolutely.
Okay. Okay. Thank you very much, everyone. Okay. Bye-bye.
Okay.
All right.
Bye-bye.
Have a great day.